Okay, hello everybody. Welcome to this series. We've been learning a lot, so we are almost at the end of this journey. So today we are going to have a view on obstetrics and in COVID-19 and in critical care, and see what the oxygen requirement is and how you can deal with pregnant women. So I think we can get right into it. Okay. So, sorry, I was having an issue. Something keeps popping up. Okay, so today we're having a 28-year-old pregnant woman who presents with fatigue and shortness of breath. As we said, this is part 10, where we're doing obstetric considerations for oxygen and critical care. So WHO organization, just going through, the main thing is maternal mortality is unacceptably high. So our aim is actually to prevent the maternal mortality. And every day in 2017, approximately 810 women died from preventable causes related to pregnancy and childbirth. And majority of the maternal death occurs in the lower income countries. So, and maternal mortality is highest for adolescent girls, which who are between 10 and 14 years and face a higher risk of complication and death as a result of pregnancy than any other women. So they are adolescent, they're not fully functional, like in terms of like an adult. So their body is not ready. So that's how some of these complications are very common. And also the inadequate access to quality healthcare. So today we have certain objectives that we need to meet. So the first one is that we need to list the physiological changes that occur with pregnancy. We need to describe how physiological changes of pregnancy affect maternal well-being. We need to describe how physiological changes of pregnancy affect disease presentation. Describe the changes in arterial blood gas that occurs during pregnancy. List the goals of oxygen therapy in pregnant women. Recognize and describe signs of maternal distress. Recognize and describe signs of fetal distress. List the multidisciplinary team members required for optimal care of critically ill pregnant patients, and describe the unique considerations during resuscitation of pregnant women. Utilize cognitive aids for obstetric emergency, and be able to access COVID-19 protocols for obstetric patients. So the objectives look quite a lot, but I think by the end of this case study, we should have been able to achieve most of them. So we can go down to the case study. Is everyone, because I feel like there's some people who are saying they can't hear. Sarah, everyone can hear?
I can hear you. I can hear you.
Okay.
Yes. Yeah, you sound good.
Okay, no problem. So we have a 28-year-old pregnant woman with a gestation of 29 weeks, presents with fatigue and shortness of breath. Her symptoms started 2 days ago with a quote-unquote stuffy nose, rhinorrhea, feeling of fever, although she had not checked her own temperature. Her pregnancy has been uncomplicated, but now she's concerned that she does not feel much of the fetal movements for the last day. She's a teacher. She's not aware of any exposure to SARS-CoV-2, but does interact with children daily. So from her obstetric history, she's 2 previous and complicated term deliveries, history of hypothyroidism. In the past medical history, surgical history is none. The social history, lives at home with her mother, her 2 children, and her husband. Her medication, she uses levothyroxine, and she has no allergies. So scroll down. So the practical change objectives is to list the physiological changes that occur with pregnancy, describe how physiological changes of pregnancy affect maternal well-being, describe how physiological changes of pregnancy affect disease presentation, and also to describe changes in arterial blood gas that occur in pregnancy. So the first part is a question where, as Sarah had indicated, we are going to respond in the chat box. Oh, okay, yeah, there's a poll. So each of the following are normal physiological changes for pregnant patients in the cardiovascular system, except. So each of the following are normal physiological changes that occur in pregnant women in the cardiovascular system, except. So there's A, which is increased cardiac output due to increased heart rate and stroke volume, dilutional anemia from increased plasma volume, there's supine hypotension syndrome, autocaval compression by the gravid uterus, and increased blood pressure due to high systemic vascular resistance. So maybe we can have your answers in the poll. Thank you. People are very receptive. Okay, some more people, just give you a few more seconds to answer the question, and we can be able to discuss. Okay. Everybody, you want us to, okay, let me, a few more seconds and then we can close the poll. Okay, I think we can close the poll. So most people answered the answer as E. So, which is the increased blood pressure due to the high systemic vascular resistance. So in the cardiovascular system, you're going to have a few things that increase in the pregnant woman, in bearing in mind that there is another factor who is the fetus. So you have to increase the amount of blood volume for this, for the patient. So you're going to increase the cardiac output, and we are going to see an increase in maternal heart rate as high as early as even in the 5th week of gestation. And by the 3rd trimester, it increases by up to 20%. It is even higher than the non-pregnant woman. The cardiac output starts to increase also very early, even by the 10th week of gestation, and it increases up to 30 to 50% above the baseline. Also, due to the increase in cardiac output, we actually, and the plasma volume, will notice that there is dilutional anemia in women. Supine hypotension is likely a cause also because they have reduced systemic vascular resistance, as opposed to answer E, which says that there is an increase. And also the progesterone also helps to causes smooth muscle relaxation, which gives an element of hypotension. So there's also the autocaval compression by the gravid uterus, especially So that's why most of the time we tell pregnant women to lie on the left lateral position. So our answer is E. Okay, I think we can continue to the next question. So the next question is, each of the following are normal physiological changes for pregnant patients in the respiratory system, except, so these are changes in the respiratory system, except there is decreased oxygen consumption, there is increased tidal volume and respiratory rate, there is respiratory alkalosis, decreased functional residual capacity, and rapid desaturation during periods of apnea. Okay, so I think we can open the poll, just answer. Okay, a few more people. Just give a few more seconds for you to answer. Okay. I think we can close the poll. So most people had A as the answer, which is decreased oxygen consumption, and that is the false answer. So if anything, there is an increased oxygen demand in a pregnant woman, so it means that the consumption is higher. When we go to the tidal volume, you'll notice that there is an increase in minute ventilation, and minute ventilation is a factor of tidal volume and respiratory rate. So both tidal volume increase and the respiratory rate increases. Due to the increase in respirate also, we're going to find in their BGA that we'll find some sort of respiratory alkalosis. Then due to the increase in the gravid uterus, we'll find that there is a compression in the lung capacity. So there will be a decreased functional residual capacity. And due to this, due to the reduced functional residual capacity, pregnant women tend to desaturate very fast when they get an episode of apnea, or even when you're trying to intubate a pregnant woman, you'll find that they desaturate very fast. So that is one of the reasons. So next question, true or false? This one is very quick. Dyspnea is common during pregnancy, occurring in 60 to 70% of healthy pregnant women. True or false? Okay, a few more seconds. Yes, thank you. So many people are answering. This is nice. Okay, I think we can close the poll. So most people said true, which is the true answer. So most pregnant women end up having some sort of dyspnea, and especially as the patient has so many changes, that are occurring. But what you need to differentiate between these patients is that you need to check and see that it is not an abnormal sort of dyspnea.
You guys want to go to the
So to
supermarket?
say, somebody's microphone is on. Okay, so what I'm saying is, for these patients, you need to be, just pregnant women, as you said, in general, it's very common for them to have dyspnea, but you need to check that the dyspnea is not, it's very common at times to find that some of the dyspnea is not like a normal thing, it is pathological. So you need to watch out, especially in pregnancy. There is high risk of getting pulmonary embolism in these patients. In this era of COVID-19, dyspnea is very common. Some women have maybe stable during in their non-pregnant state. And then you find that pregnancy will tip over some cardiac disease that was just mild and it was not an issue before the pregnancy. Now, due to the increased work of the heart, you might find patients are even going to some sort of cardiac failure. So as much as the dyspnea is common, but you need to also do extra investigation or ask the patient more, or even do some investigations to find out and to make sure that it is normal dyspnea and not pathological dyspnea. Okay, so the next part of the question, pregnant patients, pregnant patients have an increase in tidal volume and respirate in their normal physiological changes in pregnancy. What changes do you expect in the Rbga? I think I had already alluded to this, but maybe some people can just write something in the chat box. I had already alluded to the increase in respirate and in tidal volume. What picture do you typically expect to get in a Rbga? Anyone? Just give a few seconds, then we can move. What picture do you expect to see in the Rbga for this patient? Thank you. Anthony Musyoki, can see your answer. Yeah, I can see most of you have written the answers that have come in the chat box. It's true. We tend to see a picture of respiratory alkalosis. And from what we said, there is an increase in the respiratory rate. That means if we increase the respiratory rate, we are going to blow off more of the CO2. So it means that our CO2 is going to be lower than normal. So we'll end up with a picture of respiratory alkalosis. If you have any question, just make sure you just put it in the chat box. So list some obstetric causes for dyspnea and acute respiratory failure. List some obstetric causes for dyspnea and acute respiratory failure. I think maybe we can just, do you want us to go through this quickly? Because I'd already alluded to it. Sorry, it's okay, you can scroll up. So for the dyspnea, as we had even categorized even in the children, you notice that there were some that were upper airway, some are lower airway causes. So some of these patients in the head, neck, ears, nose and throat, we can have some angioedema, anaphylaxis, pharyngeal infections, deep neck infections, foreign body, and neck trauma. Of note is that angioedema is actually a normal physiological change that occurs in pregnant women. And that's why even some of the patients, it's really difficult to also intubate them. And some of them also get a hoarse voice because of this angioedema in pregnancy. In the chest wall, you can have fractures or a frail chest. Not too common, but it can happen. In the pulmonary system, causes of dyspnea, like the ones we had mentioned, patient can have COPD, asthma, pulmonary embolism is a very common thing to check out for because, as you said, they have increased volume. Some of the patients don't move a lot and they end up getting DVT, and it's so easy for them to have to throw an embolism. Pneumothorax, pulmonary infections, ARDS, COVID-19 is also a common cause also. In the cardiac, we can have acute coronary disease. We can have heart failure. As I alluded to, there are some patients who before pregnancy are normal, but maybe they had mild heart conditions. And due to the increase in volume, it tips them over to congestive heart failure. Some can have pulmonary edema, cardiomyopathy, arrhythmias. Neurologically, you can have a stroke or a neuromuscular disease. Metabolism, in the metabolism, in case this patient, some of them, I don't know, you can have poisoning, salicylates, carbon monoxide poisoning, toxic ingestion, and also a very common thing also is diabetic ketoacidosis, sepsis, and anemia. Actually, the last three are very common in pregnancy. So, and other miscellaneous issues, differential diagnosis can be anxiety, pneumomediastinitis, and intra-abdominal processes, ascites, and pregnancy itself. Those are some of the differential diagnoses of dyspnea. I feel we can continue. So a case update is the patient is found to be having contractions, but they are irregular and occur approximately every 8 to 12 minutes. Her cervix is closed on examination. The maternal vital signs, the temperature is 38.9 degrees Celsius, heart rate is 115, blood pressure is 140/75, respirate is 18, and SpO2 is 91% on room air. The fetal monitoring, heart rate is 125. So what are the lists? So from this, just keep in mind what we have already said, what the case update is as we are continuing down. So list the goals of oxygen therapy in pregnant women, recognize and describe signs of maternal distress, recognize and describe signs of fetal distress. So according to the Society of Maternal and Fetal Medicine, a group of high-risk pregnancy experts, what is the goal of SpO2 in pregnant patients? So what is the goal of SpO2 in pregnant patients? Maybe you can write the answers in the chat box, then you can be able to discuss. So what are the goals of SpO2 in pregnant patients? Are they different from non-pregnant patients? Anyone who knows the goal? Okay, I think we'll just move on from that. And so for pregnant women, as we are saying, yeah, maybe you can click on the resource. It was quite a bit of a read. It was 33 pages, but when you scroll down, you'll notice that the goal is for pregnant women, we want their saturations to be 95%. Yeah, normal patients will recommend at 92, but for a patient who is pregnant is generally 95, greater than, says greater than, there's a place where it says 95%. Yes, so for pregnant women, we want the saturations to be greater than 95%. And for non-pregnant women, as we have been discussing in the other sessions, it's 92%. So this is where we want to maintain, because don't forget that their oxygen requirement is high because of the fetal growth as well, requirement as well. Okay, so we can go to the next question. We'll send all these resources to the chat box, then you can be able to see. Which of the following oxygen delivery devices can be used in pregnant patients? Which of the following oxygen devices can be used in pregnant patients? So kindly just do the poll. Okay, let's take a few more seconds and then we can continue. Okay, I think we can end the poll. So I see most of you have said all of the above, which is true. You can use any delivery device for pregnant patients as long as you give the appropriate amount of oxygen as we had discussed per patient. If it is a mask with a reservoir, you need to give between 10 to 15 liters. If it is nasal prongs, we're going to give between 1 to 5. If it's high flow nasal cannulas, you need to know you can give between 30 to 50. And if the patient is not improving beyond the 50 liters per minute, you need to consider other options for this patient. So all of the above is true. So we have a case update on this patient. So the patient, let's see, is there another quiz? So a case update, the patient is placed on oxygen by nasal cannula at 4 liters per minute. Initially, her SpO2 improves to 92 to 93%. Remember, it was 91%. But an hour later, she requires 10 liters per minute by a non-rebreather mask. to maintain an oxygen saturation of 95%. The health facility to which this patient presents does not have a neonatal care unit or staff to care for the preterm baby, nor does it have an adult ICU. The decision is made to transfer her to a center with appropriate multidisciplinary team. So in one systematic review, 75% of pregnant patients who contracted COVID-19 were asymptomatic. What are considered danger signs for a pregnant woman that should prompt her to present for clinical care? So they're saying most of the patients, 75% of the patients are symptomatic. But what are those danger signs that are there in a pregnant woman that will prompt her to seek clinical care? So I think there are a few, maybe like a minute to see if you have some answers in the chat box. What are some of the things that will prompt a pregnant woman to present herself for clinical care? We just have a few people writing in the chat box. What are some of the danger signs? What do you look out for? Even when you're advising women in ANC, what do you tell them to look out for so that they come back to the hospital immediately? Hemorrhage, thank you. So someone who's written hemorrhage. What else? Anyone else? Severe headaches, true. Fever, vomiting, limb edema. Thank you. Sama and Lillian. Okay, so maybe let's just go through it. We have an article that outlines some of the things that you need to look out for and which have been mentioned, which is true. For these patients, there are some of the things that warrant a patient to come to hospital when they have COVID-19. So if a patient starts becoming suddenly very dysnic, and then there's, I'm sorry, when the oxygen saturation, if a patient has a pulse oximeter, when you notice it is dropping below, we said the target is 95%. So if it starts dropping below 95%, that should warrant a patient to come to hospital. So someone mentioned about the blood pressure. You can either have a hypotension or a hypertension. Both are very dangerous. If you have hypotension, remember you can compromise the fetal circulation as well. So if you have a systolic blood pressure of less than 90, you need to go to hospital. Hypertension, if you have systolic blood pressures of above 140. If the patient has persistent fevers, like in this patient, you'll notice the patient had was febrile. So if you have fevers of greater than 38, you need to go to hospital. Respiratory greater than 30, and then maternal tachycardia. Then the other things, as you've said, what are the signs of maybe preeclampsia or HELP? Someone mentioned the headaches, the severe headaches, epigastric pain. Those are some of the things that will prompt a patient to come to hospital. So those are some of the danger signs. Okay. Maybe we can continue. So fetal distress is a very broad term which can be used in many clinical situations. Although it is difficult to give a precise clinical definition, obstetricians usually use this term to indicate that the fetus is becoming hypoxic. Oh, you've already gone to the, okay. Sorry, let me give you a minute. So we're saying fetal distress is a very broad term which can be used in many clinical situations. Although it is difficult to give a precise clinical definition, obstetricians usually use this term to indicate that the fetus is becoming hypoxic. Immediate delivery has to be considered because neurological damage may occur when the fetal brain is deprived of oxygen. Antipartum fetal screening is used to assess hypoxia in high-risk patients, and monitoring during labor supplies information on the status of the fetus prior to the birth. So the question that we have, what are the options to monitor fetal well-being? What options, what do we use to monitor the fetal well-being in our setting? Maybe let me put it closer to where we work. What do we use to monitor the fetal heart rate or the fetal well-being? Maybe let's write something in the chat box. Thank you. I can see someone has already written something. Good. Thank you, Lillian. Any other thing that we commonly use, especially in our public hospitals? What do you use in your public hospital? I can only see one answer, and it's not commonly available in most. It is the ideal, but it's not what is available. Yes, thank you. We use the fetal scope and the ultrasound. Thank you. And a CTG. So those are the answers I was looking for. A fetal scope is the most common thing that you will find in any government institution, followed by an ultrasound and a CTG. Thank you for the responses. So a quick poll on the next part. So we're doing the fetal well-being. So which one of the following is a reassuring sign of fetal well-being? Which of the following is a reassuring sign in the fetal well-being? Let's do the poll quickly. Okay, I think we can close the poll. So which of the following is the reassuring sign? So the most reassuring sign from this one, have we closed the poll? So I see most of you got the answer is D. The fetal heart rate has to be between 10 to 16 beats per minute. So for the fetal heart rate, the late deceleration of fetal heart rate is not a good sign. So we are supposed to have an early deceleration. An early deceleration occurs when we start having a contraction, and it should not be sustained for so long. Then there is some, so the rest, we'll send you the article, then you can be able to see how to grade it. But for sure, like even when you use the fetal scalp and you get some sample, the pH should not be below 7.2 as well. And there's supposed to be some base variability in the heart rate of around 5 beats per minute. So the normal heart rate for the fetus is between 110 and 160. So it should not be below 110, it should not be above 160. Let's scroll up. Today's lesson is quite long. So the objective is to list the multidisciplinary team members required for optimal care of a critically ill pregnant patient. Maybe we can just do this one because it's a very quick one. What do you need to manage a patient who's list the multidisciplinary members required for optimal care of a critically ill pregnant patient? Let's see some answers in the chat box. Thank you. Obstetric and gynecologist, thank you. A pediatrician, thank you. A competent nurse, thank you. Internal medicine. Thank you. A midwife, good. Critical care, nurse. Yes, so managing this patient will need a multidisciplinary team because like this patient, as you're saying, this patient is 29 weeks. So we might opt for an emergency CS, which will need an obs-gyn. This patient is preterm, so definitely needs a pediatrician and will need a critical care nurse. We need an anesthesiologist or an anesthetist in this situation, even a CO or a doctor, as long as everyone has a role to play in this, in the role of this patient. So what monitors should be placed on this patient? As you're saying, this patient is critically ill. So what do you think? What monitors should we place on this patient? This one should be an easy one. We have done these equipments before. Yes, I can see. Thank you. I can see cardiac monitors. I can see a CTG. Thank you. Diagnostic ECG leads. True. We're suspecting this patient has hypoxia probably. So what will we use? Yes, a pulse oximeter, a BP cuff. Thank you. So I think you've mentioned most of the things that this patient is a must-have. In this patient, you must put full monitors. You'll need an ECG, you'll need BP, you'll need a pulse oximeter, and we've already mentioned an ECG and a CTG in this patient. Placing, you can also do the fetal scope if that is what is available, even the Doppler ultrasound if that is what you have. So the next part for the patient transfer, she's placed in an ambulance. She's currently receiving oxygen by an rebreather, 10 liters per minute on an e-cylinder. The pressure on the cylinder is 2000 PSI. How long will the oxygen tank last before it runs out? So how long will it take? So for this patient, the patient is doing 10 liters per minute. So If it's 10 liters per minute, you want to see how long it will last. So you'll multiply and get like, what is it called? What is the per hour? How many liters does this patient require? So you're going to do the 10 times 60, which is 600 for the patient. So, and then you have a cylinder type E. A type E has 680 liters. So if you're going to consume 600 liters per minute, and this E cylinder is 680 liters, it means we can only use it for approximately 1 hour. I think we're going to send you, and then you can be able to see what different cylinder capacities are there. So a type E is 680 liters. I hope you've understood. If you're doing 10 liters per minute, maybe just say. Okay, then you'll be able to calculate and see from that result. So you see, we've said 10 liters per minute. So 10 times the number of minutes per hours, which is 60. So we get 600 liters per minute. This one is 680. So you have approximately 1 hour to use the cylinder. So I hope everyone has been able to, so that's how you approximate even the use of a patient when you're transferring a patient. So if you have a journey for more than 1 hour, you should carry a backup for this patient. So for the next session, I think I'll hand over to Dr. Rachael so that she can proceed from there. Dr. Rachael, welcome.
Okay. Good evening, everyone. Thanks, Eunice, for the wonderful elaboration in your presentation. I hope I'm clear. Sorry, there could be some background noise, but hope it will not be disruptive to everyone. So I'll continue with this session. We'll have a case update of the same patient. So unfortunately, the patient's status has worsened during transport to the hospital. She continues to contract intermittently, and her cervix remains closed. Upon arrival, her status is as follows. The maternal vitals are temperature. She has a fever. Temperature is 39.1. Heart rate is 125. She's a bit tachypnic because we all know that in an adult it's above 100. Blood pressure is normal, 105/60 with a MAP of 75. Respirations are 25. This is slightly high, though at times in pregnancy we have patients who could be a bit tachypnic because of the pressure of the uterus on the diaphragm, so they tend to be hyperventilating. SpO2 is at 90% on 10 liters per minute of oxygen by mask with reservoir bag. Her heart rate is the fetal heart rate is 105. There are variable decelerations, minimal variability. Could go down, kindly, Alana. So practice change objectives. Describe the unique considerations during resuscitation of a pregnant woman. Utilize cognitive aids for obstetric emergencies. Be able to access COVID protocols for obstetric patients. List at least one unique intervention used during maternal resuscitation. So what intervention in your facility do you usually use when you have maybe a mother who's coming and requires resuscitation? Either she could be in shock, she could be having sepsis, or she could be having some sort of febrile high fevers without a known cause. What kind of resuscitation would you give? I can give a minute or half a minute to this, or at least some few responses. Anyone with a specific intervention that they usually give for resuscitation of a maternal mother? Okay. I seem not to be having any answers, but what we need to know, the same resuscitation that you do in any adult patient or a child is the same considerations you'd have to use for even a maternal mother. So if they're tachypnic, you have to think about whether to give oxygen. If they're having low BPs, you have to think, am I going to do a fluid resuscitation? If they're having the fevers, what's the cause of the fevers? How am I going to treat the fevers? So you probably give your paracetamol. Someone says left lateral to prevent autocaval compression, which is true. This will improve the BPs. So it's also a way of trying to improve your BPs in a situation whereby you have hypotension. So the same ABCs that you use in resuscitation is the same ABCs that you use in maternal mothers. But remember, at times the hypoxia could be caused because of the splinting of the diaphragm, because of the pressure of the diaphragm, of the uterus on the diaphragm, and also there are more oxygen requirements. So at least giving some sort of oxygen supplementation can improve in case of a patient who has hypoxia. So we can continue down. So a case update. Upon arrival to the hospital, the patient is found with continuous contractions. Her cervix remains closed. She has now become more somnolent and is difficult to arouse. The following information is obtained on arrival. So you have a BG of 7.34, which is not too bad because the normal pH is 7.35 to 7.45. PCO2 is 40, PO2 is 100. She's on 10 liters of oxygen. Bicarbonate is 20. Full blood count is 20,000. I'm not sure what units they use. HB is 7. Platelet is 95. C-reactive is slightly elevated. ALT is elevated. Chest X-ray shows multifocal bilateral parenchymal opacities. Fetal assessment is 155, moderate variability, and recurrent variable decelerations. Can we go down? True or false? The following arterial blood gas is normal for patients at this gestational age. pH of 7.35, PCO2 of 40, PO2 of 100, and bicarb of 20. True or false? So majority, I've lost the poll. Wow. Okay. Majority are saying true. Okay, still answers. I can give another 1 second, or rather half a second. Okay, so we can end the poll. So majority are saying that it's true, 55%, others are saying 45%. So what the background of this is that you need to know that maternal mothers tend to hyperventilate. So when you're hyperventilating, you have some sort of respiratory alkalosis. When you have respiratory alkalosis, what will happen to your pH could be slightly higher than above the 7.35. So that's what's showing. And then your PCO2, because you're hyperventilating, your PCO2 will be on the lower level, and your PO2 should actually be probably towards normal. So in this lady, this PO2 is 100, is almost normal at 100 milligrams of mercury, but she's having 10 liters of oxygen. So is this normal for her gestational age? Remember, the lady was at, what gestation was she at? So I have to go up. She's at an advanced gestational age. So
Dr. Eunice, I think we lost Dr. Rachel. Are you able to fill in? Dr. Eunice?
Hello?
Oh, I think we lost Dr. Rachel.
Okay. So where were we? Physiological. As she was saying, these are some of the expected changes in our BGA for our patient. And as I had alluded to earlier, that these patients are having, they're going to hyperventilate. So we expect such a kind of a picture in their BGA. So this is a normal BGA in a pregnant patient. Maybe we can continue. Sorry. So suddenly, the patient loses consciousness. She's emergently intubated for hypoxemia and is transferred to ICU. She has begun to contract regularly every 5 minutes, but her cervix is closed. But there's a small amount of blood noted on the vaginal introitus. So the maternal vital signs: temperature of 39 degrees Celsius, heart rate of 120 beats per minute, blood pressure has reduced significantly. She's hypotensive at 95/45, but her saturations remain at 95%. Mechanical ventilation setting, we're using a pressure control ventilation mode. FiO2, we're using FiO2 of 70, respirate of 20, tidal volume of 6 mils per kg. We are putting a PEEP of 10 and a pressure, plateau pressure of 35 centimeters of water. The fetal heart rate, you can appreciate that it has reduced, and there's recurrent variable deceleration and minimal variability. So maybe let's scroll down. So for the question in this, after this update, if this patient were to go into cardiac arrest, which one of the following modifications is not appropriate during ACLS for pregnant patients? If this patient were to go into cardiac arrest, which one of the following modifications is not appropriate during ACLS for pregnant patients? Let's do a quick poll. If you're resuscitating a pregnant woman, what is not appropriate to do? Tilt the patient 30 degrees to the right during CPR, manual left uterine displacement by the provider, 2 large bore IV lines placed above the level of the diaphragm, and CPR compression rate of 100 per minute, compressions per minute. A few more seconds. Okay. We can close the poll. So I see most of you got the answer. So as we said, one of the changes that occur in our pregnancy is autocaval compression. So the correct answer, which is inappropriate, will be tilting the patient 30 degrees to the right. It should be tilting the patient 30 degrees to the left, because you want the left lateral displacement of the uterus so that there is the IVC is free to actually pump back blood into the heart. So if you displace the uterus to the right side, you're going to cause autocaval compression. The others are true. You need large lines so that you can be able to administer your drugs. Above the diaphragm is more preferred so that it goes straight to the heart, where if adrenaline, the shot goes straight to the heart and it's acting. Compressions, as per ACLS, we do 100 compression. So in a crisis or clinical emergency, which of the following actions have you observed when providers cannot remember how to manage a certain situation? So in a crisis or clinical emergency, which of the following actions have you observed when providers cannot remember how to manage a certain clinical condition? Anyone? So maybe I think, let me paraphrase this question, because even for me, I had a bit of an issue. I think from what this question is asking, if you are probably resuscitating a patient and you are unable to do something, like you forget what the next step is, what do people commonly do? Do they call for a colleague to help? Do they use the internet? Do they go through a textbook? Do some run away? What are the options available if you cannot remember how you're supposed to manage a patient? So I think I can close the poll. I can say maybe this question had a bit of it was a twist, but if you're not able to remember an action that you need to do, you're allowed to refer, you're allowed to call a colleague. You can even call somebody to check what you're supposed to do next. So you shouldn't feel like you're trapped and alone when you're doing a resuscitation or when you need to help with a patient. So always consult, always ask for extra help. Okay. So there's an obstetric emergency manual. I don't know if it opens, and then you can be able to, you'll be sent for this material. Then you'll be able to go through the various things that you need for emergency management of obstetric patients. So maybe we can go down to the case update. So that information will be sent to you, or you can scan that code and you can get the information. So the patient is diagnosed with acute respiratory distress syndrome from presumed SARS-CoV-2 or COVID-19. She's placed on lung protective ventilator settings, as you've noted above, on the mechanical ventilation. And the maternal fetal medicine specialists are the following. And the maternal fetal medicine specialists are the following: the clinical status of the patients and the fetus. Okay. So what is one strategy to improve oxygenation in ARDS is to place the patient in prone position. So one of the strategies that we've actually discussed when we did the topic of ARDS is that we can do prone positioning. So is it possible to do prone positioning in pregnant women? Maybe we can watch a clip that is there.
We will be demonstrating the prone positioning of an intubated pregnant patient. Note there are 5 to 6 assistants, 1 at the head of the bed, 2 on each side, and 1 at the foot of the bed if available. All movements will be made at the direction and count of the respiratory therapist or lead personnel at the head of the bed. This person is responsible for ensuring the security of the ET tube and support of the head and neck. For the proning maneuver, the patient will be turned towards the ventilator. First, a flat sheet will be placed underneath the patient by rolling the patient to one side, placing the sheet underneath so that it may be passed to the other side, and then rolling to the opposite side to complete the placement of the lower sheet. Once the patient is returned to the supine position, monitors including EKG electrodes may be removed. Next, 3 sets of pillows will be placed on the patient. The first 2 pillows are placed on the chest above the gravid abdomen, the second 2 over the pelvic area below the gravid abdomen, and the third set over the lower legs. A second flat sheet will then be placed over the pillows and the patient. The assistants on each side will roll the 2 sheets together towards the patient, encasing her in the cocoon fashion. The sheets must be rolled tightly to ensure stability of the pillows during turning. Again, all maneuvers will be made at the direction and count of the person at the head of the bed. The next maneuver is to slide the patient away from the ventilator. The patient will then be rolled onto her side by the assistants on the ventilator side pushing under while the assistants on the opposite side push over. The person at the foot of the bed will help guide the feet. Once on her side, the assistants will switch hand position prior to the final prone maneuver. The assistants towards the ventilator will have their hands on top and pull forward and downward, while the assistants on the opposite side pull upward. Once prone, the head should be turned to one side and supported. Monitors can be replaced and the ET tube checked for security and patency. Pillows may be adjusted as needed. Next, we will check for space between the abdomen and the bed to ensure that the uterus is offloaded and fetal monitors can be placed. The arms can be positioned towards the head, down to the side, or one of each in the so-called swimmer's position. The head should be turned and the arms repositioned every 2 hours to avoid skin abrasions and pressure ulcers. All maneuvers can be reversed to return the patient to the supine position.
Okay, so as you've noted, so we are saying it is possible for you to use prone position in pregnant women, but it is with caution. And as you have seen, even turning this patient and even how you manage them, even when you put the pillows and everything is very specific, and you need a lot of manpower for this patient. But yes, it is actually possible to put them in prone position. So we are about to come to the end. So what other considerations are required when caring for pregnant patients with COVID-19? What other considerations are required when caring for pregnant patients with COVID-19? So there is a resource, you can click on it. It's a very quick one. From the clinical highlights is, we can just do the highlights, Sarah. So we're saying pregnant women at higher risk of contracting COVID-19, and pregnancy actually gives them a higher risk of morbidity and mortality. The risk factors for COVID-19 are similar in pregnancy, and there is plausible vertical transmission from the mother to the child. It has been observed in some neonates, though it is rare. Some of the considerations, as we've said, there is a threatened preterm birth in pregnancy. So it will be safe to actually give these patients dexamethasone early so that we can preempt and actually cause some sort of lung maturity in the preterm. So you will give the 10 milligrams IM for 3 days. If you can push it up to 3 days, give 3 consecutive days, and then so that you can at least get some lung maturation, and that way we can decrease the level of ARDS in the newborn, quote unquote, the preterm also when they are born. So clinicians should also have a lower threshold for thromboprophylaxis in mothers with COVID-19. So you'd rather give these patients early prophylaxis than wait until we get a thrombotic event. As you're saying, pregnancy is already a high risk for patients to get a thrombotic event. So just have a lower threshold of thromboprophylaxis for these patients. Mothers who have COVID-19 are encouraged to breastfeed if they are able, and what they should just do is just wear a mask when they're breastfeeding. That way you are just able to protect the baby from transmission. Asymptomatic COVID-19 in pregnancy appears to be common, but is of uncertain clinical significance. Clinicians should be mindful of wider implications of the pandemic, ensure that screening takes place for mental health, distress, and intimate patient violence where possible. So, so these are some of the highlights. and some of the things that we'll send you this resource so that you'll be able to see. But this is the highlight of the article. So these are some of the things you need to bear in mind. Thromboprophylaxis of the patient, giving of the patient corticosteroids early to develop the lungs of the preterm is common, and also breastfeed, that the patient breastfeed as long as they're protective to the child. So I think that is more or less. Let's see if there's anything we are left with. I think we have, yeah, knowing what must be done does away with fear. So that is the motto. So if you know what you need to do, you can actually do it without fear. So we've actually come to the end of the session. I know it was a bit long, but I hope that we have learned a lot from this session. I want to thank Sarah. Thank you, Assist International, for bringing this session together and continuing to support us. Also, thank you, Dr. Rachael, for being a good mentor to all of us. And I'll hand over to Sarah.
Before you hand over, Eunice, thank you so much. Sorry, I had some internet features, connectivity, but thank you so much for your presentation as well and your contribution to everyone who contributed to this initiative and to this platform. Whatever responses you made, they could be wrong, they could be right in adult learning. Everything is right, but you explained to Father. So thank you so much for making time. And thank you as well, Assist International and Project ECHO, for making this happen. And yeah, we wish you everyone a lovely evening. So for anyone who's new, these sessions have been happening every the first Friday of every month. Today was session 10, so we have two more sessions left in the first Friday of every month. So we hope to get you guys in the next two sessions. And we hope also that Project ECHO and Assist International will make this more continuous. Even when the 12 sessions end, we'll get something else depending on the needs of the users or the people who are participating. We'll create more learning platforms and more topics to discuss. So thank you once again. Alana, over to you.
Wonderful. Thank you, Dr. Rachael. Thank you, Dr. Eunice. And thank you to everyone who called in to participate today. As they said, please save the date for our next session. We will be discussing essential emergency and critical care on April 1st. So in about a month's time. And until then, if you have any questions about the content, feel free to ask them in the WhatsApp group. I'll share the QR code for that. And otherwise, we hope to see you then. Have a nice evening.